Welcome to this episode of Early Detect Studios. I'm Sheena Gill, president of CognitiveCare, and today I'm thrilled to share we are featuring Dr. Shantanu Nundy. Dr. Nundy is a primary care physician, technologist, and business leader who serves as chief medical officer for Accolade. In addition, he practices primary care in the greater Washington, D.C. area and serves as a senior advisor to the World Bank and a lecturer in health policy at the George Washington University. Previously, he was director of the Human Diagnosis Project, a healthcare AI startup, which he successfully built into the world's largest open medical project spanning 80 countries. Prior to that, he was managing director for clinical innovation at 𝗗𝗏𝗀𝗃 Health and was also co-inventor of SMS DM Care, an automated text messaging software for individuals with diabetes. Dr. Nundy is a graduate of MIT, Johns Hopkins University for medical school, and the University of Chicago for his MBA. And fun fact, guys, Dr. Shantanu and I graduated high school together. So with that, welcome. Shantanu, how are you? Pleasure to have you on today.
It's great to be on, Sheena. And I was going to say, that's my greatest claim to fame is I was a classmate.
Wonderful. So I thought maybe we could start with perhaps share a bit about Accolade. We would love to hear your mission, what your solutions are. Tell us a little bit more about where you are right now.
Sure, absolutely. Yeah. So Accolade was started with a very, very simple idea. And I wish I could take credit for it, but it wasn't mine, which is that healthcare is really complex, right? When your kid's sick or you're trying to figure out where to get a test or what to do with a new diagnosis of cancer, it's really, really complicated. And it's not just the health side of it that's complicated, it's the financial side. Like how much it's going to cost? How can I afford it? Can I get days off of work? And what's my maternity leave? So it started with the really simple idea of what if we could pair every person with a personal health assistant, somebody who a lot of our people, they're social workers or ex-teachers or firefighters who are trained in how the healthcare system works, has access to your data through your employer, and then together partners with you to help you manage the next steps in your health. So that's what Accolade does.
Wonderful. So tell us a little bit about your journey getting to Accolade. What inspired you to take this path? We'd love to hear your personal journey.
Yeah, I mean, I grew up loving to build things, back in high school when I'd be bored in class and we didn't have computers or phones back then. We had our TI-83s, you remember? I used to program games.
Yeah, I do remember that, yes.
And we'd have to actually connect the calculators to share a game from one person to anyway. So I used to like building things. And then in college, one of my aunts actually runs a school for girls in a village in India. So I went to go to teach English, and I didn't know anything. I was 17 at the time, but the kids seemed really sick to me. And I was like, how can you learn if you're feeling sick? So anyways, with the local doctor, we got all the girls physicals, and then we got them access to medications and vaccines that they didn't have, and ended up with some money from MIT building a school there. And that's kind of what got me addicted to this idea of I love building things, I really love health and healthcare. And so if I could bring those two sides together, and so that's what I've been doing, is just trying to tinker and build things ever since. And so when I got the call from Accolade, at the point that they called me, this was about 3 years ago, we had about 2 million members that we were doing this health assistant navigation for.
Right.
And they said, hey, we now want to take our model and now add to it and do more things for people. And so it was a chance to build, it was a chance to lead, and for a service that I believed in. And so, took the leap, and it's been really great.
Wonderful. So, a little over a year ago, your book, Care After COVID, I actually have it right here, guys. It was published, and it was described when it came out as an action plan for reinventing healthcare in the post-pandemic world by the who's who in healthcare. And as you know, I read your book way before I even knew this interview was going to happen. And I found it to be, really phenomenal, yet quite practical. Because I know of your clinical experience and your business acumen and your engineering mindset. And on top of all that, you have this profound passion to help the underserved. I was really intrigued by your 3D model that you described in the book, which is, the distributed care, the digitally enabled, and decentralized care as well. And it was very transformative in my mind, the way you described that. So let's, if you don't mind, can we talk a little bit about that? Maybe one at a time. Let's start with the distributed care. So what I thought was really interesting about this concept in your book was, to you, it doesn't just mean, virtual care or moving health homeward necessarily, but rather where the patients are. And I just, that was really thought provoking for me. So please share to our audience a little bit more about what this means, and how do you think this will impact primary care in the future?
Yeah, absolutely. Well, I'm glad it resonated, Sheena. So,
Mhm.
yeah, I mean, I was really purposeful with the words that I chose, right? Because I think right now, in particular, everyone's saying, oh, virtual, 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 and now home, home, home. And I wanted to pick words that were really counterpoints in a way to that. So you're right. Distributed was this idea of, look, let's just meet people where they are. Now, a lot of people, including myself, happen to be online. So let's do that and let's be virtual. A lot of people are homebound. So let's do that and meet them at home, or prefer to be home for whatever reason. Other people, they're in church. Other people, they're in the barber shop. And so I think sometimes we've lost the core principle, which is exactly what you said: meet people where they are, and where they are is at home, or where they are is online, or wherever that is. And that's really the principle that I wanted to hit. And in part of that is because, when we see people in clinic or a hospital, wherever we are, already a number of healthcare decisions have been made. I mean,
Right.
oftentimes the biggest decision to make is, should I actually access care? Right? That's
Mhm.
oftentimes the biggest difference between someone, if you say someone that has a heart attack that goes really badly, or someone that doesn't, or someone that prevents diabetes, or someone doesn't, the biggest decision was when they decided to even seek care. So we have to meet people in that moment,
Right.
and then sort of guide them along. And if we don't do that, we might be missing the biggest leverage point to impact their health and well-being.
Yeah, I think that was a really phenomenal point, and something that I think will resonate with a lot of stakeholders in healthcare. So the next of the 3D model that you described is digitally enabled. And, everyone is using this phrase, but you used it a little differently, which I thought was really creative, in the sense that you describe it as using data and technology to strengthen relationships, but your focus was on the strengthening the relationships, right? Using that data and technology to strengthen relationships. And I thought that was really a very, very interesting perspective, coming from a clinician who's also who has been an entrepreneur, who has an engineering mindset. Like you understand what we need, but what it's important for.
Yeah.
And so please expand upon this and how it's changing, but not replacing care models.
Yeah, absolutely. So yeah, I mean, it's really simple. If you just even start outside of healthcare, right? When my wife and I text each other through the day, I'm not trying to replace my time with her, right? It's I'm using a really simple technology so that we're communicating through the day, and actually strengthens our relationship. We're more on on the same page about what's happening with our kids and things at home. It's the same thing. I mean, during COVID, one of the interesting things that happened to my clinic, I take care of largely uninsured folks, and so a lot of my visits were audio only, and I did it on my cell phone. But the beauty was, I suddenly had their cell phone number and they had mine.
Hmm.
And it was just simple things, right? They would text me and say, "Hey, Dr. Nundy, I'm so, so, so sorry to bother you." Patients are always like this, right? People think I give them my cell phone number. They text me all the time. They don't. They're like, "I tried this, 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 and this, and this. My refill runs out tomorrow. I need my blood thinner. Otherwise, I'm going to get another blood clot. Can you help me?" And I'm like, "Of
Mm.
course I can help you." And like,
Right.
okay, I just took care of your refill and it's done, right? That's the kinds of things that we're talking about. The same is true on the physician to physician side too, by the way. We don't talk about this enough, but medicine is really collaborative. If you think about that classic old painting of doctors, they're all in this room and there's a patient, they're all like together in residency, we're all together. But once you're in the real world of medicine, like I am, you're alone
Yeah.
and there's no one there to help you. And so the other kind of digital enablement we need and the relationships we need is between physicians themselves. Like, hey, I got this weird case, or hey, what do you do about this? Or hey, can you help me with that? And that's a really important type of connectivity as well that we need. And then, of course, there's between patients and their caregivers, or patients and their families. That was another amazing thing that happened during the pandemic, is I got to meet a lot of my patients' families,
Mm.
because they were doing, it's hard enough for one person to have to miss work to show up to my office and wait for an hour, but for two people or
Right.
three or four. And so suddenly I had a whole families on Zoom with me. And it was incredible, because that's who's going to help you change the behaviors you need,
Right.
right?
True.
Particularly when it comes to chronic conditions.
And give you so much more insight to what otherwise may not be readily transparent from a medical record, right? So,
Absolutely.
right,
The
gives
number of
real
patients I
context.
have that say, "I'm fine,"
Yeah.
especially And the wife's like, well, what about these 6 things? And it changes the conversation and it improves people's health, right?
Exactly.
Yeah.
Exactly. That's so fascinating. So the last element of the 3D model you described is decentralization, and it's also another very thought-provoking element. It seems from what you described that an alignment of incentives alone is just part of the solution. And so when you combine things like value-based care with real empowerment, so for
Yeah.
example, knowing who is at risk early, which is of course very of significant interest to us here at Cognitive Care, and also empowering physicians with the ability to get actual resources to patients who need it most. Decentralized could really help move the needle in ways. And so, share with our audience a little bit more about this concept.
Yeah, yeah, it's the most conceptual. So, example that I find helpful is, this patient, like every doctor does, who's in and out of the hospital with heart failure. And after one of these hospitalizations, she came and I said, remember, check your weight every day. And if it's up a couple pounds, just give me a call or take a little extra dose of your fluid pill. And then I asked her, I said, wait, do you have a weighing scale? And she looks at the ground, as if she has any reason to be embarrassed. And she goes, no, I don't. And anyways, I ended up getting her a weighing scale and she never got hospitalized with heart failure again.
Wow.
And it's just one of those things where when I say decentralized, what I mean is in that moment, if I wanted to write her a prescription for a $10,000 heart failure medication, if I wanted to admit her for cardiac catheterization, I could do that like that.
Right.
But if I wanted to get this woman a weighing scale, which is $20, I wasn't able to do that. I actually gave her $20 out of my wallet. That's how I did it.
Wow.
And that's the problem, because when people talk about value-based care, which I completely agree with, it's only necessary but not sufficient.
Right.
Because you're that in a value-based care environment, the doctor still can only do what they can actually charge for. And they're not freed up to be able to say, well, this person needs that cardiac cath, this person needs that heart failure medicine, this person just needs a darn weighing scale.
Right.
And if once you give us the resources and or the patients, by the way, I think then you're going to start to see this shift happen in large part because you're personalizing.
Right.
You're personalizing the care people need to get. And you're not doing the one size fits all. And another good example, which I think a lot about these days, is, it's become very popular to like give people a ride to clinic. Well, Penn Medicine, someone did a randomized control study. They gave half the people a ride, half the people didn't get a ride. Guess what? It had no impact on appointment attendance. And why? Because 80% of the people didn't need a ride. That wasn't a barrier for them. Right? So it's a good idea, but only if you personalize it. So if I gave every heart failure patient a weighing scale, it probably wouldn't make a difference either. It made a difference for her. And who knows which of the 100 things to give her? Well, it's the doctor, the nurse, the dietitian, the pharmacist, and the patient and their family. And that's where we need to decentralize resources to.
That makes a lot of sense. So it seems like decentralization really helps amplify that personalization. And that story that you just shared about the weighing machine is so powerful. I mean, think about that. Think about how you bent the cost curve in addition to improving outcomes. I mean, it solves so many challenges from so many different angles. The pandemic has amplified long-standing healthcare disparities, impacting vulnerable populations significantly, and highlighting that there is much work to be done to advance health equity. Now, with the benefit of one more year after the writing of your book, which truly and did a fabulous job of already underscoring this assertion, what are the top 1 or 2 things that you think everyone in healthcare should be focusing on right now? So take, for example, something very close to our hearts here at Cognitive Care is maternal health. And it's absolutely unacceptable that 21% of women, birthing persons in this country, receive late, no, or inadequate prenatal care. It's unacceptable that Black women are 3 times more likely to die from pregnancy-related complications. So what are your thoughts? What are the things that you think we need to be focusing on in healthcare?
Yeah, it's such an important question. And you're right. It's totally heartbreaking to hear those statistics. We should never get numb to them. I think there's so much good work happening right now, right? People are focusing on the diversity of the health workforce. People are focusing on payment models and looking at SDOH type payments. There's so much good stuff. I think for me, my starting point, I think this thing that I still want to keep elevating the conversation is looking at the core care experience, right? So like that example you gave of very significant number of women, particularly minoritized women, who aren't getting enough prenatal care. Let's look at the core model. right? The core model says that, you have to have 4 or 5 or 6 prenatal visits. You need to do them between 9 a.m. and 3 p.m. when the clinic's open. And
Right.
that core care model just may be impossible for too many of those
Right.
women, right? And so you could yell at them and you can give them free parking and do stuff, but that's not going to solve their core barriers. So for me, the part that I keep pushing for is let's look at the core experience and saying, do we need to reinvent this care model? Can we achieve those same quality measures and the same outcomes or better by looking at it and saying, does every single one of those visits have to happen at a doctor's office? Can we give them some of that equipment to take home with them? Can we do a couple of those checks virtually? Can we do some at-home tests? We need to look at those things and ask ourselves, are these things sort of set up to fail? And how can we instead design for those marginalized communities and patients first and come up with a care model that can achieve more?
Excellent points. So on that note, are you seeing any success stories that you would like to share?
Oh, there's so many. There's really so many. I mean, I just think about my own clinic, part of what was fun is I saw so many patients where I always asked them like, oh, when was the last time you saw a doctor? And I had so many patients say 5 years or 6 years or 10 years. And I said, well, hey, what brought you back?
Mhm.
And it was like, well, because I can do this virtually with you. That made such a huge difference, right? And so we can debate endlessly, like is virtual or in person, virtual versus in person, but just acknowledging that when 25 to 40% of working Americans, don't have a primary care physician, clearly the current options that are available aren't working for people, almost by definition. And so what
Right.
I'm seeing in so many places, including maternity, is people saying, let's just create more care models. And we're moving to the world where in addition to personalized medicine, which is I'm going to use your genome and proteome and design a medicine for you, it's personalized healthcare delivery. It's I'm going to understand your preferences, where you like to be met, what your work schedule and life schedule is, and how do I just provide a care model that works for you. And so I have a lot of optimism right now that we're seeing those new care models come up, and that they're meeting more and more of those people where they are.
That's really wonderful to hear. So considering, your 3D model, your own experiences as an entrepreneur, as an executive, as a physician, I'm curious, what is the one thing that you want folks that are in the healthcare startup world, innovators out there that are trying to, improve healthcare? What are the one or two things that you want them to take away from what you've written and all that you share in your work?
Oh, wow. Well, I think first thing I always say is, you know, no innovation in the world or AI or technology is going to solve for the fact that everyone in this country needs access to high quality healthcare coverage and care. And how we vote matters, and the
Mhm.
decisions we make in our political lives matter. And innovation is not a replacement for that. It's a substitute and a complement to that. So there's too many people who are talking about these things, but then their other actions aren't consistent with those things. So that's the first thing I'd say.
Mhm.
The second thing is that yeah, I mean, I think too much of the healthcare system, we need leadership. You know, we need people to really think about the problem, think about the people, question the way that things are. I mean, look at a good example is the testing that we did for COVID, right? Where the drive-through testing as an example. There's no reason why we couldn't have been doing that for decades, right? There's no new technology needed. In fact, the payment model, fee for service, you can see way more patients faster drive-through than you can in a clinic.
That's
And
an
yet
interesting
it
point.
took a
Yeah.
pandemic. Yeah, it took a pandemic for us to do it. And now, as we're heading to flu season again in a month or two, let's see how many clinics still have it. And so we really need to lead the change. And I think there's too much of like, well, I would do that, but there's policy, or I do. And of course, those things matter. It's a complicated ecosystem, but all of us have way more agency to change the system in the direction that's going to make it improve care for all than we acknowledge. And that just requires us to step up, just like we did during the pandemic. Look at what we did. It was phenomenal what we did. A lot of things could have been better, but to me, it gives me hope that we can create change in healthcare.
That's fabulous, and I love your optimism. Your optimism was so evident in the book as well. And Shantu, thank you so much. And I am personally really proud of all of that you have achieved. Knowing you since you were 14 years old, you represent the best of the profession. You bring an interdisciplinary and innovative mindset to the very complex task of improving care in this country. And I wish you every continued success.
Oh, thanks so much, Sheena. Yeah.
It was wonderful having you. To our audience, I hope you really enjoyed this episode with Dr. Shantanu Nundy. And until next time, be well.